So the first examination maneuver that we can use to assess for shoulder laxity and or instability is the SULCUS sign. Now the SULCUS sign is used for the assessment of inferior laxity. That's how it's described in the orthopedic textbooks. But you can actually use the SULCUS sign to assess for laxity in any of the directions. And it's just simply up to you, doctor, to perform the SULCUS maneuver in a variety of different planes of space to uncover these subtle instabilities that might not otherwise manifest in the absence of you actually trying to find it. But anyway, so the SULCUS sign is described in the AMA guides as used for the assessment of inferior laxity. Now, the SULCUS sign can be applied with or without added traction. Now, if you notice a SULCUS sign, which is simply a noticeable dimple in the skin below the acromion process due to failure of the head of the humerus to remain in the glenoid cavity. Now, if you see a SULCUS sign in the absence of applied traction, this indicates that this is the examinee's walking around condition. They walk around with a lax and drooping shoulder, and this is indicative of simply laxity. This is their walking around condition, probably not reproductive of pain. It's simply an indication of laxity. Now, to apply the SULCUS sign with traction, you simply stabilize the acromion process superiorly and then apply inferior traction to the head of the humerus, and any translation of the humeral head of 1 to 2 millimeters accompanied by a noticeable dimpling in the skin below the acromion process qualifies as a positive SULCUS sign. Now, the SULCUS sign is not considered to be positive for instability, even though it may be positive for laxity. And the distinction between laxity and instability is whether or not the maneuver reproduces the examinee's symptoms. And as we stated earlier, the examinee's symptoms include, number 1, pain, and number 2, muscular defense or some other positive and true objective involuntary finding. So as we get into some of these muscular defense findings and some of these voluntary reflexive findings, I want to spend some time talking about this so you understand the philosophy of these maneuvers that we're going to be talking about. And I know you've heard about the apprehension maneuver, and I want to put the apprehension maneuver kind of in a new context for you so that you apply this principle really now to all of your physical examination maneuvers. And to introduce this topic, I want to refresh your memory about something that you probably learned about in neuroanatomy class years ago, decades ago. I don't know how long ago it was that you studied this, but I want to refresh your memory on what's known as the FLEXOR withdrawal response. And what the FLEXOR withdrawal response is, it's a reflexive withdrawal from a painful stimulus, and it's mediated neurologically in a reflex arc. So without getting too detailed about the FLEXOR withdrawal response, let's just summarize it by stating that when you encounter a painful stimulus, reflexively and involuntarily, the nervous system has a set built-in programmed reflexive protective withdrawal response from the painful stimulus. And the classic example that's given in anatomy textbooks is the person who, for the first time, touches his finger to a hot stove. Well, we all know what happens when you touch your finger to a hot stove. There's an instantaneous withdrawal of your finger from the stove due to contraction of your biceps muscle. And that's a locally mediated reflex that takes place through the spinal cord. And it's a polysynaptic reflex. And you can confirm this by simply tracing out the neurologic loops. For example, if you touch the tip of your index finger to a hot stove, well, what dermatome conveys sensation from the tip of the finger? That's the C6 dermatome. Well, the C6 dermatome would convey those sensory impulses up into the C6 level of the spinal cord and create synapses with interneurons that travel both up the spinal cord to the level of C5 and down the spinal cord to the level of C7. And all of these synapses would synapse on anterior motor horn cells that contribute to the musculocutaneous nerve, which then innervates the biceps muscle. So it's polysynaptic. And without getting into all the neurologic loops of it, it's a protective response that's reflexive. In fact, it's no different than any other reflex, such as testing the biceps reflex or the patellar reflex or the Achilles reflex. It's a reflexive withdrawal response from a painful stimulus, and it's neurologic. Well, you may have heard of that, and you may have heard of its cousin also, known as the crossed extensor reflex. And the crossed extensor reflex is simply just another form of spinal cord reflex that protects us in the case of damage or injury due to painful stimuli. So the classic example that's given for a crossed extensor reflex is a person who's walking along and who steps on a piece of sharp glass or a nail, etc. Due to reflexive inhibition, that foot that steps down onto a sharp shard of glass, that foot is going to give way. That foot and that leg is going to go weak. Why is it going to go weak? It's going to go weak in order to reduce the amount of pressure that's applied onto that sharp piece of glass. Isn't that exactly the withdrawal reflex as that leg goes weak to prevent further damage? That component of the crossed extensor reflex is actually the withdrawal reflex, and it's protective. Well, simultaneously, due to multiple polysynaptic synapses through multiple levels of the spinal cord, simultaneously, the opposite leg is going to strengthen to stabilize the body. The muscles on the contralateral side are going to stiffen and contract and become strong to support the weight of the leg that is simultaneously withdrawing from the painful stimulus. So what's the point of this? What's the point of this? The point is that when we encounter a painful stimulus, whether it be a hot stove, whether it be stepping on a sharp shard of glass, whether it be encountering a bumblebee that's all of a sudden flying around your head, it causes you to fling your arm up over your head to try and swat it away, to covering your eyes when you have a bird hit the windshield of your car. All of these are reflexive, involuntary, and instantaneous protective reflexes that are built into our neurology, and they're there to protect us. Well, in our physical examination maneuvers, and especially with regards to shoulder instability, this is what the AMA guides is referring to when they talk about muscular defense. Muscular defense. What is muscular defense, and how does muscular defense manifest itself in these provocative maneuvers? It manifests itself as a crossed extensor reflex, or as a withdrawal reflex. And you will notice this. Your examinee will withdraw or maneuver or flinch or hunch or jump in such a way as to remove themselves from the dangerous or injurious or painful position or maneuver. And that's what constitutes the true positive objective finding. It's not simply the report of pain. It's the report of pain that's accompanied by some reflexive muscular defense or other protective maneuvering. So with the SULCUS sign, that would manifest itself as a withdrawal from the traction that is applied to produce the sulcus. Be on the lookout and be expecting for your examinee to withdraw and to drop their shoulder on that side in order to prevent further subluxation and or possibly dislocation. And it's that withdrawal, in addition to the finding of dimpling of the skin underneath the acromion, that would constitute a true objective finding for shoulder instability. And in the absence of the withdrawal response, the maneuver is simply positive only for laxity, but not positive for instability. Okay? So let's talk about the various planes and directions of shoulder instability, beginning with anterior and posterior instability and the associated examination maneuvers. Now, the AMA guides talk about the loading posterior/anterior drawer sign. That's the loading posterior to anterior drawer sign. And the AMA guides give us some specific instructions as to how this examination maneuver is to be performed. And as we go through the next several examination maneuvers, I'm going to be switching references back and forth between the AMA Guides 5th edition and Lippincot's Primary Care Orthopedics 2nd edition. And the reason I do that is to share with you some different perspectives as to how these examinations maneuvers are performed and how the findings on these examination maneuvers are interpreted by different references. So the AMA guides tell us that this maneuver is to be performed with the shoulder in 60 degrees of abduction and 30 degrees of flexion, with the humerus bone itself maintained in neutral rotation. And this is with the examinee supine. Okay, so 60 degrees abduction and 30 degrees of flexion. And that's actually a quite comfortable position for the examinee and for you as the doctor. Well, your one hand stabilizes the extremity in neutral rotation, while the other hand applies a posteriorly directed force through the head of the humerus and through the glenoid cavity from anterior to posterior. The force is applied posteriorward in an attempt to sublux or dislocate the shoulder posteriorly. And that's the posterior drawer. And you can apply several pulses to the posterior drawer to check or assess for the posterior component of the instability. Then the positions of your hands are just reversed to reproduce the maneuver in applying an anteriorly directed force, and you can apply several pulses of the force in an anterior direction to assess for anterior instability. And then the maneuver can finally be repeated throughout the full range of motion from anterior to posterior, always keeping on the lookout for positive objective findings. Now, according to Lippincot's, they describe a slightly different procedure. According to Lippincot's Primary Care Orthopedics, we're instructed to grab the proximal humerus and apply gentle compressive force into the glenoid fossa. Now, this is a distinction between the AMA guides and the Lippincotts. Recall that this maneuver is entitled the Loading Anterior to Posterior Drawer sign. Well, what is it that contributes to the loading of this maneuver? Well, according to Lippincotts, we load the maneuver by applying a compressive force, compressing the head of the humerus into the glenoid fossa. And the purpose of that is to slacken the capsule and to slacken the glenohumeral ligaments. Well, the AMA guides don't elaborate on what it is that qualifies as the loading component of the maneuver, but it's my opinion, and based on other orthopedic textbooks, it's my opinion that the AMA guides are referring to loading of the head of the humerus anteriorly to posteriorly versus loading the head of the humerus medially into the glenoid fossa, as is referenced by Lippincotts. Okay, so there's two slightly different distinctions, but you can simply perform the maneuver both ways. You can perform the maneuver both ways and determine for yourself if that provides any different findings for your particular examinee. Okay, so we apply a compressive force to slacken the glenohumeral ligaments. The free hand supports the elbow, and then the humeral head is then translated anteriorly and posteriorly as far over the glenoid rim as possible. And medial translation of the head of the humerus with this maneuver indicates that a subluxation has occurred, and we're instructed to document the amount of the subluxation. And you can probably picture this in your mind. Medial translation of the head of the humerus as the head of the humerus rides down and across the glenoid fossa indicates that a subluxation is occurring, and then of course frank medial translation would indicate that indeed a medial dislocation has taken place. Now, reproduction of the patient's symptoms is key. Reproduction of symptoms is key in establishing a diagnosis of either unidirectional instability and or multidirectional instability. And the sensitivity of this maneuver has been found through various case studies and research studies to be about 50%, but the specificity is 100%. And we'll talk a little bit more about sensitivity and specificity as we go on with these other maneuvers. But it's going to be an important concept which I want you to just put an asterisk next to here for just a couple moments until we come back to that. Now, in documenting the amount of translation of the head of the humerus, the AMA guides, they provide for 4 different classifications of translation. Trace is a small amount of movement of the humeral head. That would qualify as hyperlaxity. A class 1 translation is when the humeral head rides up the glenoid rim, but not over the glenoid rim. This would also qualify as hyperlaxity, meaning that the head of the humerus is quite mobile, but does not dislocate outside or over the glenoid rim. With a class 2 translation, we see that the humeral head subluxes over the glenoid rim, but when the pressure or your loading is removed, the head of the humerus reduces spontaneously back to its normal position. And then finally, with a class 3 translation, the humeral head frankly dislocates over the glenoid rim and remains dislocated even with the removal of the force. And if the head of the humerus is dislocating anteriorly, we refer to that as anterior instability. and if it moves posteriorly, we refer to that as posterior instability. Now the question that I have for you is, with the Class 2 and Class 3 translations, how would muscular defense play into the amount of translation that you're actually going to be able to identify? It's my experience and it's my opinion that it's going to be rare that we see Class 2 and Class 3 translations because of the muscular defense. And your examinee is simply not going to allow you to frankly dislocate their shoulder over the glenoid rim. And so that does not mean that we do not have a Class 2 or Class 3. It's just that it's difficult to assess with this maneuver. And so we'll talk about some of the other ways that you can classify the translation with some of these other maneuvers that we'll talk about now. Now, after the loading an anterior and posterior drawer sign, the AMA guides require that we perform the apprehension sign. The apprehension sign, or the apprehension test. And to perform the apprehension test, we have our examinee supine, and we test for anterior instability. So the anterior apprehension test is performed by applying external rotation as the shoulder is held in 90 degrees of abduction. So I want you to picture this in your mind. Your examinee is lying there supine with their hands on their abdomen, and you as the examiner take that hand away from the abdomen and move the shoulder into 90 degrees of shoulder abduction. This is a passive movement performed by the doctor, correct? Now, it is possible that in moving the shoulder from the side of the torso to 90 degrees of abduction, you could elicit an apprehension sign. That's not exactly how the maneuver is described, but many times examinees don't read the textbook, and it is possible to have apprehension and instability at any point throughout the performance of the maneuver. But anyway, as you get the shoulder into its position of 90 degrees of abduction, then you simply start increasing or applying external rotation to the humerus bone, meanwhile maintaining the humerus in 90 degrees of abduction. Now, in the case of anterior instability, this increasing external rotation at the glenohumeral joint slackens the middle and inferior glenohumeral ligaments. And in the case of instability, if the individual fears that the humeral head is going to come out of socket, they will report pain, and you will observe a withdrawal reflex or a muscular defense or a crossed extensor reflex or some involuntary protective reflex that protects against the motion. It protects against the motion. And so it usually opposes the motion. Now, simply the presence of pain is not necessarily diagnostic of instability. It may be suggestive of hyperlaxity, but it's not diagnostic of instability. Now, let me ask you, with anterior instability, where will your examinee experience pain? Well, the pain is going to be experienced posteriorly, and the muscular defense is going to be manifest posteriorly, and the pain comes from the muscular defense posteriorly as those posterior muscles try to oppose the sliding of the head of the humerus in an anterior direction. Now, Lippincot's Orthopedics describes the apprehension sign slightly differently, but basically the same. They say that patients with unidirectional instability will typically demonstrate anxiety as their shoulder is abducted and externally rotated while in the supine position, because this maneuver reproduces the sensation of an impending dislocation. Now, picture this in your mind. What would an apprehension sign look like? It would look like a little flinch, a little jump, a little withdrawal, just like the jump and the tense and the flinch that you experience when you tap an examinee's biceps reflex, or their patellar reflex, or their Achilles reflex. It's a little muscular defense reaction. It's instantaneous. It may be subtle, it may be profound, but it's there, and when it's there, it's a true objective finding. Now, according to Lippincotts, the apprehension sign, when it's positive, meaning it's accompanied by pain and muscular defense, it's indicative of anterior instability of the glenohumeral joint, and it has a sensitivity of 53 to 68% and a specificity of 99%. And what does it mean to have a sensitivity of 68% and a specificity of 99%? Well, let's talk about that. When we talk about the sensitivity of an examination maneuver, we're referring to the ability of that examination maneuver to correctly and properly identify the true positives. So the sensitivity is a measure of the true positives. How well able is this examination maneuver to detect those persons actually that have anterior instability? How sensitive of a test is it for the condition of anterior instability? Specificity, on the other hand, is the opposite. Specificity is the ability of the examination maneuver to identify the true negatives, the people who do not have shoulder instability. And according to Lippincotts Primary Care Orthopedics, and as I referenced earlier from the AMA guides, describe the loading anterior posterior maneuver as having 100% specificity. So what that means is, with regards to the sensitivity, this apprehension maneuver is 68% sensitive, meaning that it picks up the true positives, people that actually have this condition. Now, it's not 100% sensitive, and that means that some people who do not have anterior instability could give you your positive findings, such as pain and such as muscular defense, but the pain and the muscular defense is due to a condition different than anterior instability. It's not a 100% sensitive test only for anterior instability. It has a sensitivity of 68% according to Lippincotts Primary Care Orthopedics. On the other hand, the specificity, which is a measure of the true negative rate, is 99%. And that means that people without anterior instability, who do not have this condition, they will not have a positive test. The test is very specific in identifying those without the condition. Those without the condition will not respond to this maneuver. So that's a very valuable information. You know that when you get a positive finding, a positive apprehension sign, there's a good chance, a very high likelihood, that that's due to anterior instability. And our sensitivity and specificity goes up even more when we add in our third maneuver, which is described in the AMA guides as the anterior relocation sign, also referenced in the literature as JOBE'S sign. Now, with JOBE'S sign is basically a confirmatory maneuver for the apprehension sign. So, according to the AMA guides, the relocation maneuver is performed by applying a posteriorly directed force to the proximal humerus while the shoulder is in 90 degrees abduction and external rotation in the supine position. So that's our apprehension position, 90 degrees abduction, 30 and external rotation. And imagine this. So we go through the apprehension maneuver and our examinee gives us an apprehension sign accompanied by muscular defense. Well, how can we make our examinee more comfortable? We make our examinee more comfortable by reducing the feeling of impending dislocation. How could we do that? Well, JOBE'S maneuver, or the relocation maneuver, describes applying a force to drive the head of the humerus posteriorly. How else could we do that? We could do that by reducing the external rotation. We could do that by reducing the abduction. We could do that by reducing both simultaneously, also while applying a posteriorly directed force. In other words, the relocation maneuver is any type of maneuver that makes the examinee more comfortable by properly positioning the head of the humerus. Make sense? Okay, Lippincott says that relief of apprehension with a posteriorly directed force on the humeral head is also a confirmatory test for anterior instability. Now, the relocation test has a sensitivity of 100% and a specificity, has a sensitivity of 57% and a specificity of 100% for diagnosing anterior instability in the presence of a positive apprehension sign. So what that means is that if your examinee gives you a positive apprehension sign, which is then relieved by the relocation maneuver, they have anterior instability, because people without the condition will not respond to this maneuver. So taken together, if you get a negative apprehension sign or you get a positive apprehension sign with a positive relocation test, that tells you there's a good chance, in fact there's a 57% chance, that what your examinee is suffering from is anterior instability. And it's my opinion that we don't perform these maneuvers often enough. You'll be surprised at how many examinees will report pain with these maneuvers, especially as the external rotation increases. And it's comforting to know that 100% specificity means that those persons without anterior instability will not have positive findings on these maneuvers. So these maneuvers are very accurate maneuvers, at least for the condition of anterior instability. A couple other tests I want to go over with you that we'll demonstrate here in our examination maneuvers coming up. Number one is the FULCRUM test, and these are just takeoffs or variations on the apprehension sign that take the humerus bone through various ranges of motion and different planes to assess for different directional instabilities. Now, the FULCRUM test is used to test also for anterior instability. The examinee is supine, And they begin in the apprehension position with the shoulder abducted to 90 degrees and the head of the humerus externally rotated, which in itself is the anterior apprehension maneuver. And then to increase the force anteriorly, perhaps to detect some of the more subtle instabilities, you as the examiner place one hand posterior to the humeral head while externally rotating and extending the arm over the fulcrum, which is your hand. And with your hand, you can apply an anteriorly directed force while simultaneously increasing the external rotation of the humerus and then extending the arm over the fulcrum, which is your hand. This further stretches all of the anterior joint capsule and the anterior glenohumeral ligaments. And it may be that you need to get the examinee in this type of a position to locate the exact position that reproduces the instability. And this is a good test to use for those examinees whose job duties require repetitive overhead motions, because the test itself takes their arm up and overhead. So this is a good maneuver. A couple key points is that the precise position of your hand is important to properly apply the force over the fulcrum. And like our other tests, we're looking for three things. We're looking for translation of the humeral head, we're looking for reports of pain, and then of course we're looking for a true objective finding in the form of an apprehension sign. And then finally, the fifth test that I want to share with you, and we'll demonstrate this here in just a moment in some video tapings that I have for you. The fifth test is known as the LABRAL CLUNK test. LABRAL CLUNK test. And the beauty of the LABRAL CLUNK test is this test allows you to assess for the cause of the instability, because this test assesses for instability due to tear or rupture of the glenoid labrum. So in order to perform the LABRAL CLUNK test, you start with the examinee supine and with the shoulder fully abducted, meaning 180 degrees overhead. And it may be that in positioning the arm in this position, you may get an apprehension sign before you even get there. But assuming that you can get the arm 180 degrees overhead, the maneuver then begins from there. And of course, this would be a good maneuver to use for those persons who perform repetitive overhead motions. So with the arm 180 degrees overhead, you grasp the distal humerus with one hand, while the other hand is placed proximally under the posterior shoulder. Now, the hand underneath the posterior shoulder is going to be used to apply an anteriorly directed force, while the proximal hand repetitively, internally and externally rotates the humerus bone within the glenoid fossa. And any reproduction of symptoms such as pain, apprehension, fear, and even clunking, grating, joint crepitus, or other joint noises which are indicative of joint pathomechanics would be considered a positive test, in this case for instability due to a tear of the glenoid labrum. Okay? So that was 5 physical examination maneuvers.